10 to 30% of U.S. women have some form of polycystic ovary syndrome.
Welcome to Commune. We are on a mission to inspire, heal, and bring the world closer together. Sara Gottfried, we meet again.
Hello, Jeff Krasno.
It's just a delight to be here with you, as always. Today, we are fielding a question that seems to be coming up more and more in our community related to PCOS, Polycystic Ovarian Syndrome. And so a little bit of couple data points here. So PCOS affects an estimated 10% of reproductive-aged women. That's 5 million women in the United States, approximately. And up to 70% of affected women are undiagnosed. So it really impacts a tremendous amount of people, and they don't know it. And it appears that PCOS is the most common cause of anovulation and a leading cause of infertility. So, help us understand, what is PCOS?
PCOS is a syndrome. And as you may know, Jeff, with other syndromes, there's not one cause.
Right.
It tends to be multifactorial, tends to be that there's what we call phenotypic heterogeneity. So, there's people who are thin and lean who have PCOS. There are women who are overweight and obese who have PCOS. We don't know truly the cause, but we've got a lot of ideas based on the phenotype, based on what we see with people who struggle with PCOS. And I appreciate the stats that you shared at the beginning, because I think this point about 70% being undiagnosed is critical. And so I feel like that is a sacred opportunity and invitation for podcasts like this, so that we can spread the word and really generate conversations around why your period is coming less often than it used to. Maybe it's happening every 2 months, or you're skipping and you go 3 months in between.
And is that one of the primary presentations?
That's one of the primary presentations. So there's a constellation of symptoms, and you might have one or more of these. Typically, you need at least 2 to meet criteria. There's a few different criteria out there, like Rotterdam and a few others. But basically, what's known as ovulation, oligomenorrhea, and that just means you're not getting a cycle every 28 days. So it could be every 36 days, and then 48 days, and so forth. Typically, there's also signs of androgen excess. So androgen is it's the growth and repair family of hormones that includes testosterone, it includes DHEA. And when you have excess testosterone, that can lead to acne, can lead to rogue hairs, like on your chin, around your breasts, and places that you don't want it. Mm-hmm. And it can lead to other symptoms of just having too much testosterone coursing through your body. Mm-hmm. The third thing that we can see, the third factor, is cysts on the ovaries. So this is where the name comes from, which in some ways is kind of unfortunate, because you don't have to have an ultrasound diagnosis. But right. On ultrasound, what we're looking for is a pattern that's called the string of pearls. And that's when there's these small little follicles around the surface of the ovary that are just kind of sitting there. They're about 1 centimeter in size, and it looks like you've got your grandmother's pearl necklace sitting there in your ovary. So we can see that on ultrasound, and that is characteristic of someone with PCOS.
That's not where you want your heirlooms.
You don't want your heirlooms there, for sure.
No.
But one other point you made, you said that this is one of the leading causes of infertility. Absolutely true. But what I want women to also understand is that this is something that affects you throughout the life cycle. So beginning at puberty, the women who don't have a menstrual cycle every single month, we want to be thinking, is there an issue, for instance, with insulin resistance that's happening in adolescence that we need to address now, so that this person doesn't then struggle with fertility when they're in their 20s and 30s and they want to have a baby? And then most important, the number one cause of death in the US is cardiovascular disease. The main driver of cardiovascular disease with women with PCOS is the high testosterone levels. That's the biomarker that we worry about the most. So a lot of people think, oh yeah, I had PCOS, you know, I had trouble getting pregnant. I took metformin, it helped me ovulate, and then I got pregnant, or I took Clomid and that helped me get pregnant. I'm done with that PCOS story. No, it continues. So once you go through menopause, you want to be thinking, oh, this is an atypical risk factor for cardiometabolic disease as you get older. It needs to be tracked.
So let's say, I mean, most women aren't necessarily going in to get an ultrasound willy-nilly. So symptoms like you mentioned, presentation of acne or maybe facial hair or other places that you don't want hair, that would be sort of the first potential indication that you might have. And I mean, obviously there's a whole psychological element to that, right? Because for younger women particularly, there's a lot of shame and guilt associated with acne, particularly like we've talked about. I have teenage daughters. So how would a woman, how do you get diagnosed essentially with PCOS if you're not getting an ultrasound and seeing the pearl necklace there?
So you need to go see a clinician who's experienced with diagnosing polycystic ovary syndrome. And so pretty much any board certified gynecologist is going to be experienced at this. It doesn't require, advanced training. It's really bread and butter work that a gynecologist performs. Mm-hmm. I think the question is the index of suspicion. So as someone who thinks a lot about health span and thinks a lot about men and women and some of these levers that we can pull to make our quality of life fabulous for as long as possible, I think PCOS is one of those things that really robs us of health span. So with that in mind, I've got a high index of suspicion. So you mentioned that based on the best epidemiology, we think about 10% of women are affected. But I can tell you in conversations, dinner conversations with friends of mine who are endocrinologists, we think it's much more common. We know that metabolic dysfunction is becoming more and more prevalent, especially in the United States. We think that it may be more like 10 to 30% of US women have some form of polycystic ovary syndrome.
Wow.
So we've got this rising problem of insulin resistance and obesity and overweight.
Yeah. Now I've heard different theories posited that insulin and hyperinsulinemia inhibits aromatase, a particular enzyme that is useful in converting testosterone to estrogen. It might play some sort of role in high levels of testosterone. But as you say, PCOS seems to be characterized by high levels of testosterone, but not necessarily low levels of estrogen. Is that right?
That's right. I think of 3 different hormones involved, maybe 4, with PCOS. So the focus tends to be on the androgens and looking almost exclusively at testosterone. But there's a bigger story here. And that is if you've got elevated testosterone levels, which is actually very similar to the metabolic dysfunction we see in men who have low testosterone.
Right.
So they're akin, which we'll get to maybe in a moment.
Yeah.
But there's also, as someone who pays a lot of attention to hormones, I'm thinking of the role of insulin, the role of testosterone, how most people with PCOS also have estrogen dominance. So they tend to have a higher level of estradiol overall. They're not ovulating regularly. They're not having that monthly menstrual cycle. And because they're not ovulating, they have low progesterone levels. So it's not just a testosterone problem. And then just to bring in one other hormone, that's cortisol. So we know there's a lot of stress dysregulation and problems with the hypothalamic pituitary adrenal axis, which controls cortisol, which is really at the top of the hierarchy in terms of hormones.
Yeah. And cortisol can trigger elevated blood glucose, which then is triggering additional insulin.
It's like a vicious cycle.
Yeah. And of course, we were designed, that was an adaptive design. Because cortisol was very, very useful. You want more blood glucose when you're being chased by an ungulate or something. You want that energy fuel available for your muscles. but you don't want it chronically every day of the week.
That's right. So you want to spike your cortisol maybe once a quarter, not every day.
Yeah. So how do you treat PCOS?
So I'm going to give you the conventional treatment, which is what I was taught.
Yeah.
So we were taught to ask a woman a pretty simple question. So say I've got a 32-year-old who meets criteria for polycystic ovarian syndrome. You ask, do you want to get pregnant? Yes or no? If the answer is yes, then we typically give them metformin if they're not ovulating, because that is an insulin sensitizer, helps with this whole cascade, reduces testosterone levels, leads to ovulation in women with polycystic ovarian syndrome. If the answer is no, we typically would give them a birth control pill. And we've talked before about some of the effects of the birth control pill, so I'm not a huge fan of that. I think women need a lot more choices, which is something that we do in integrative and functional medicine. We give women a lot more choices to address the root cause. So birth control pill or metformin, what I would prefer is that we focus first on lifestyle changes.
Yeah. So give me 3 or 4 lifestyle changes that you would recommend to address PCOS.
So number one is to reduce refined carbohydrates. So I'm a big fan of using a modified clean ketogenic diet in women with PCOS for a few reasons. Number one, we know that when you reduce carbohydrates, it can lower testosterone significantly inside of 7 days. 7 days.
Wow.
So that can really change those downstream symptoms, the rogue hairs, the acne, etc. So I'm a big fan of changing the food plan. If they're up to it, I'll do a clean ketogenic diet. If they're not up for it, we'll just start to modify carbohydrates and do that slowly. And we know that even a 5 to 10% change in body weight can hugely change the biomarkers associated with PCOS. Blood testing is mostly what I'm talking about here. So I also like in women who have acne, I like to cut out dairy and cut out gluten because that is a way of reducing inflammation. We know that inflammation is such an important driver of acne. And then I like to have stress modification as a big part of the lifestyle treatment since there's so much stress dysregulation in women with PCOS. There's a few other supplements, things like inositol, vitamin D. There's a number of insulin sensitizers like berberine. In fact, we talk about this in one of the courses that's coming up. So these are some of the supplements that I recommend, but I always have a food first philosophy where I want to start with food and then we want to layer on the supplements once you have a foundational level with food.
Okay. So we talked a little bit about how the prevalence of testosterone in women can lead to the development of these unwanted secondary sexual male characteristics like acne and rogue hairs, etc. Let's flip the script a tiny bit and talk about men. I'm 52, and one thing I dread is the ghastly development of man boobs.
Yes,
oh God, is it on the horizon for me? I've done what I can to address them in the short term. But logically, this would suggest a low testosterone and higher estrogen rate in men for curiously some of the same upstream reasons that women develop PCOS. So it's a little bit of a brain twister. So help us kind of untangle that for a moment.
Yeah, there's even a paper that talks about the similarity between PCOS and low testosterone syndrome in men. So from a metabolic perspective, they're very similar. So both are connected to insulin resistance, both are related to the development of adiposity, both draw from overnutrition and eating too much sugar, and then the downstream consequence is low T in men, high T in women. So how do we unpack this? What we know, if we just talk about man boobs for a moment, we know that tends to be estrogen that is stimulating the fat tissue around the male breast. And so we think that in men, this is related to aromatase being upregulated, usually by inflammation, so that testosterone is being overconverted to estradiol. So what I see in a lot of my male patients who've got elevated estrogen levels is that they they can have a little more fat tissue around the breasts. I have an NBA player who had an elevated estradiol, and I remember I was explaining this estradiol level to him. He was getting worked on manually in a room with a lot of the other players, and I was trying to like whisper it or keep it confidential, and he shouts out, "Dr. G, is that why my voice is like this?"
Yeah.
He drank too much alcohol. So I had to get him to stop being Dennis Rodman and to party a little bit less and, switch out that alcohol for some other things because he was doing it at the end of the game, just to try to relax.
Right.
And the alcohol can raise your estradiol level and lead to this problem of excess estradiol and boobs.
Yeah. I mean, I think what we often think of sort of the large alpha male, who's a beer drinker and, kind of rumbling around. But it turns out that those big alpha males actually have often have low testosterone and more risk at developing man boobs, et cetera, but probably even more serious than the man boobs, although no one likes to have man boobs, I suppose. But it's like what you said, like, so these kind of hypertrophic adipocytes that are like spilling fat into your bloodstream and inflammatory cytokines and adipokines and all of these things that can lead to awful downstream impacts, potentially worse than the vanity issue of man boobs.
That's right.
Yeah.
So it's vanity, but it's really this underlying issue of increased visceral fat, and that visceral fat is not a vanity issue. It is it's this cocktail that's being brewed of massive inflammation that slows down your health span, so it robs you of really healthy years. It increases your risk of chronic disease, the high blood pressure, the accelerated aging, cancer, and so forth, cardiovascular disease.
Yeah. I mean, oftentimes we come to a similar and I would call optimistic conclusion around some of these things like PCOS or man boobs, is that, we do have a good deal of agency around the development of these conditions, and they tend to be lifestyle oriented, specifically, as it pertains to our metabolic function.
That's right. And I want to call out something here, because one of the things I've noticed in the time that I've known you is that you started to wear a continuous glucose monitor. You completely changed your glucose levels. I haven't been tracking your insulin, although I'd like to.
I'd love you to.
Okay,
That's about
done.
as intimate as we can get,
Perfect.
given the circumstances.
But you've really changed the insulin resistance. When your cells become numb to insulin, you and I both had prediabetes, where our cells were they were like, insulin's at the door, knocking at the door, trying to get glucose into the cell, and our bodies were not responding in a normal way. And so we used lifestyle, mostly the way that we eat, to change our glucose curves, to change our insulin, which is the control of glucose. And that really is probably the most effective thing to reduce the risk of PCOS, although not all women with PCOS have insulin resistance, and also to prevent the visceral fat and the man boobs.
Yeah. I'd like to add on to that. For the first time in my life, I've gotten more into resistance training.
Yes.
And I know that you have too.
Yes.
And for me, outside of again, it's the opposite of man boobs. You can look good. So there's a vanity component of it, sure. But really, muscle is the biggest glucose sink. So as I have found to develop more muscles, I have an easier time regulating my blood sugar levels.
Yes.
So, and that actually gives me more elasticity in my diet, where I can actually go out and let loose here and there and not be neurotic around my diet all the time, because I've got other means of managing my glucose and upstream from there, my insulin.
Huge point. The way I think of this is inputs and outputs. So your input is related to your food. Your output is related to how you're exercising. And what I've really learned in terms of cardiometabolic function is that you should be spending about 50% of your time that you're working out with heavy lifting.
Yeah.
The other half with cardio. That's debatable, but I think from the literature, that's really the way that you get to the best cardiometabolic health. So yes, you want to spike your glucose less with the food that you're eating, but then you want to soak it up with the exercise that you're doing. And then, of course, there's the issue of stress and how much stress you have.
Yeah, absolutely. Well, I hope to get into another episode where we dive deep into exercise and what is the right amount of exercise, because this is a hotly debated issue and there's all sorts of interesting clinical study on it. So anything else that you'd like to add on this particular episode of Ask Sara, Ask Dr. G?
Well, I would say maybe as a final note, care about your insulin. So one of the things that we know is that insulin changes somewhere around 10 to 14 years before glucose changes.
Yeah.
So looking at glucose is kind of a downstream effect. Like it's really kind of late to the party. So I want to leave our listeners with a fascination with insulin. Measure your insulin. Measure your fasting insulin. It's a really easy test to do. You can ask your clinician for it. You can even do direct-to-consumer testing to look at insulin. Even postprandial insulin starts to change sooner than fasting insulin. So know what your insulin is.
There's no, at this juncture in time, there's no simple sensor or disc that I think you can slap on your triceps to measure
Not yet.
insulin. I hope that's coming. Typically, insulin hasn't been as easy to measure as glucose because it's like a small little peptide hormone
That's
thing, right? But I agree. It's 100%. It's upstream because you might have a very regulated blood glucose level. You might be having fasting glucose at like 85 or 90 and feel like you're in the clear. But that's because you're producing so much more insulin.
That's right.
To
Your
clear it
insulin's
out.
working too hard.
Yeah.
So we don't want the insulin to work too hard. We want to make the job easier for insulin.
Yeah, absolutely. Well, this is a personal journey for me. I know for you too. So this is to be continued. Thanks.
Thank you.
Hey, thanks for watching. If you like this interview from the Commune podcast, then click subscribe and check out this video right here.